Good morning, ladies and gentlemen. I warmly welcome you to the 44th Annual Academic Sessions of Candy Society of Medicine 2022. Today is the first day of our main academic sessions, and we have an interesting lineup ahead. Here at Hall A, we'll be starting the Respiratory Symposium, and in Hall B, we have the Symposium on Women's Health. In Hall C, the free paper sessions have already been started. Therefore, without further ado, let me introduce the chairpersons for the Respiratory Symposium, Dr. Manil Piris, Consultant Respiratory Physician, District General Hospital, Matale, and Dr. Damit Nandadeva, Consultant Respiratory Physician, General Hospital, Monragala.
Good morning. Welcome everybody to the first session in Hall A on respiratory diseases. It's my great pleasure to invite Dr. Amila Ratnabala, Consultant Respiratory Physician at National Hospital Kandy. He has a special interest in interstitial lung diseases and has gained a lot of experience at Oxford and has been involved in many scientific publications in this area and has been an active member of interstitial disease management in Sri Lanka since coming back.
than pirfenidone. But when it comes to the real life study, these are highly controlled studies, not real life studies. So we, in these real life studies, again, the efficacy was proven because we know that when you are diagnosed a patient with IPF in our clinic, we don't go for this strict criteria like your clinical trial, but still they have shown the efficacy. So example that you can see, these are the patients we followed up for 2 years duration, more than 2 years. And these are the, these patients, actually this cohort before the treatment of pirfenidone, and this is after the treatment of pirfenidone. You can see that for a certain period of time that they have shown stability of their lung functions. And in real life, actually, we have not only seen the stability, but also we have seen in about 7% of the time, there's improved survival or improved symptoms, improved FVC, forced vital capacity. Their lung functions, their symptoms have improved in certain percentage of patients in real life, but it has not shown in the clinical trials. If you get a safety, again, these are safe drugs, but about 86% of the time, they got at least one side effect in real life. Compared to the trials, about 98% of the time, most of the patients get side effects. So remember, whenever you are prescribing the drugs, that we are giving them a side effect at the same time. Therefore, a lot of discussion about the drug and education and how to avoid these side effects. This type of discussion is very important when you're offering these drugs for the patients. It is not a drug that you prescribe and just forget about it. And then in real life, again, the commonest side effects are, as I discussed, appetite loss and weight loss, nausea, diarrhea, and all. And then even in the capacity and ascent trials, they are the same. Basically, they are the GI side effects plus photosensitive rashes. So whenever they go outside, we should ask them to wear protective clothing as well as sun protective creams. Nintedanib, again, that we in real life, these are the patients with pirfenidone which have declined with pirfenidone has been stabilized by nintedanib. So there are no head-to-head clinical trials, but real life, we know that patient who did not tolerate or who did not respond to this pirfenidone had a better outcome with nintedanib. Unfortunately, this drug is really expensive in Sri Lanka. The safety profile, again, as I said, it is diarrhea is the main worry, but it is mild in most of the cases, but only 5% of the patients get severe diarrhea. But there's a theoretical risk of vascular thrombosis and bleeding because these drugs are acting on the vascular derived endothelial growth factors. However, it is not proven, but if the patients are on anticoagulation, we are not generally offering these drugs. So if you consider the future of this condition, the fibrotic disease, actually we have identified almost all the fibrotic pathways now. There are so many molecules are studying and there are new molecules are coming in future. So we hope that one day we might be able to reverse the fibrotic process. Then the most common interstitial lung disease that we encounter is the systemic sclerosis interstitial lung disease. Again, as you know, the interstitial lung disease is the most common cause for the death, and 35% is due to lung fibrosis, about 26% due to the pulmonary hypertension, and again, about another 26% is due to the cardiac disorders. And you might know this is a very famous trial published in New England Journal of Medicine in 2006, scleroderma lung study 1, which they have given oral cyclophosphamide as placebo. You can see that there's a 50% improvement when you treat with cyclophosphamide orally. But later there were few issues came about the tolerability of oral cyclophosphamide. They have compared with oral versus intravenous cyclophosphamide, and they found that the safety and the tolerability is more with intravenous cyclophosphamide than with oral cyclophosphamide. And then this again very famous scleroderma lung study 2, which they have studied the mycophenolate versus oral cyclophosphamide. They found that mycophenolate is equally efficacious with cyclophosphamide, and but tolerability is better with mycophenolate mofetil. And then the new drug, I think you might be aware, this tocilizumab, which has been studied for COVID-19, and it has been studied for systemic sclerosis, and they have mainly tried that for the skin, but however they found there's a benefit in the lung. The lung function decline was reduced with the treatment of tocilizumab, which is the IL-6 inhibitor monoclonal antibody. And this, again, there's a trial called Sensis trial, which has been studied, the nintedanib, the drug that I told you before, for the systemic sclerosis interstitial lung disease. And they have basically found that this drug is efficacious, especially when the systemic sclerosis is more fibrotic type. And then there are future trials actually coming on for this particular disease, systemic sclerosis lung disease. I mean, pirfenidone with mycophenolate trial is ongoing, as well as pirfenidone alone trial is also going on. And then I'll discuss about this myositis interstitial lung disease. Again, that is very common. These patients with myositis, their ANAs are usually negative. I mean, you think that patients with severe ILD, they come with severe shortness of breath, like organizing pneumonia or some pneumonia like, but they are not responding to antibiotics. Then we'll see that there's an interstitial lung disease. And we do the ANA, but ANA is commonly negative in these patients. So remember always to get a good history regarding their muscle pain. Recently, we had a patient actually who ANA was negative, but she has classical Gorton papules as well as the muscle tenderness and muscle pain. So likewise, it is important to ask the history. Again, history is very important to discuss about, to evaluate regarding the this muscle pain and muscle tenderness. And then again, if there's myositis, again, it has a favorable diagnosis, but most of the patients without myositis, that their CPKs are normal, they might have severe interstitial lung disease. Therefore, it is always important to do the autoimmune screening apart from ANA, but again, when it comes to the cost, it is very costly and not available in the government sector. But this drug, I think you are aware of this rituximab, which is a CD20 monoclonal antibody, which is showing remarkable benefit in systemic myositis-related interstitial lung disease. I mean, there's a clinical trial. We are waiting for that this year, most likely. But this drug is amazing for myositis-related interstitial lung disease, which shows significant improvement. And then I'll discuss briefly about the chronic fibrosing interstitial lung disease. Remember that most of the interstitial lung disease I discussed previously, the exposure-related interstitial lung diseases, or it could be connective tissue disease, interstitial lung disease, or most of these interstitial lung disease, whatever the treatment they offer, there's a certain percentage, roughly about 30% of the patient, they will progress with time. So these are called chronic progressive interstitial lung diseases. So there are certain phenotype of these lung diseases, whatever the treatment you offer, they will go into progression. So their pathophysiology, I'm not going to discuss much. They have a common genetic background, and there are various common exposures. Ultimately, they lead to this common fibrosing form of interstitial lung disease, whatever their type of interstitial lung disease. So do you have enough data to suspect CF-ILD? Yes. I mean, we have data that 30% of the patients, whatever the treatment you offer, they will fibrose without any reversibility. Yes, but we do not have. I mean, we can't predict this phenotype for the timing, but there are so many studies going on with neutrophils and peripheral monocytes to predict this progressive fibrosing interstitial lung disease. Again, the treatment is antifibrotics that we have. Nintedanib has been shown beneficial in this particular group of drugs, particular group of diseases, where that it halts the progression of the chronic fibrosing forms of interstitial lung disease. I mean, there are various etiologies they have tried, but almost all the etiologies, they have proven that this drug is halting the progression of the disease. And then, I mean, this antifibrotic drug pirfenidone, if you can't classify the particular interstitial lung disease, again, that they have offered pirfenidone and they have tried this, again, they have shown that certain benefit in that particular group. So I'll discuss finally about the ILD model. So I think you are very commonly aware of this CKD, chronic kidney disease model of the this model, that we have CKD, active disease. We offer a specific treatment. For example, if the patient has systemic lupus erythematosus and there's a lupus nephritis, we do a biopsy and then categorize what is the type of it, and we offer the immunosuppressive treatment to control the disease. But if it is progressing without any benefit, again, we go for the nephroprotective therapies like the ACE inhibitors, ARBs and on, and then we go for the nephroprotective therapy. So therefore, we are basically treating for the scarring kidney. And then ultimately we offer renal replacement therapy. So it is quite same in the case of CKD, but there are certain CKDs like CKD-U that we do not know the etiology, but we, from the beginning, we offer the nephroprotective therapies, and ultimately at the late stage, we offer the renal replacement therapy. So it is likewise that, I mean, in IPF or in lung diseases, there are non-IPF interstitial lung diseases where there are no fibrosis at the beginning. We offer the disease-specific therapies. We suppress the immunity and see whether they are working. And if it is not And if it is progressing, we start their kind of lung protective therapies, which includes antifibrotics and all. And this IPF is equal to CKDU, where we offer the lung protective therapies from the beginning, because we don't know the exact etiology to control the initial disease mechanisms. So my take-home message are, whatever the sophisticated disease that we are dealing with, the basic is that basics are matters. So basically, the history, detailed history would do in most of the cases. 90% of the time, it is important to get the history, and then the examination, then the basic investigations, and the principles that we should have to have a proper diagnosis before treatment. And whenever we offer treatment, we should discuss with the patient regarding the outcome as well as the side effects, because these patients might going to suffer in long term. So there should be a good discussion between the doctor and the patient. And thank you so much. And I'd like to answer if there are any questions at the end of the presentation. Thank you.
Thank you very much, Amila, for your insightful and evidence-based lecture and for sticking to time strictly. In the interest of time, we'll have the question session at the end of the symposium. Thank you very much.
Thank you.
Now I would like to introduce our next speaker. Dr. Abudhini Bhulpitya is a consultant in critical care medicine. Completed MD in medicine in 2014 and underwent overseas fellowship at Queen Alexandra Hospital in UK from 2016. She is currently working as a consultant in critical care medicine at National Hospital Kandy and her special interests are in the intensive care management of COVID and tropical infections. She was instrumental in the management of severe COVID pneumonia patients in Kandy over the previous pandemic. And so I think she is highly qualified to speak to us regarding the disease spectrum and treatment of COVID infection. Without further ado, over to you, Dr. Bhulpitya.
Thank you very much for that kind introduction. I'm thankful to the Kandy Society of Medicine for giving me this opportunity to speak to you all about disease spectrum and treatment of COVID infection. So I will briefly go through the epidemiology about the current variants, disease spectrum, investigations, treatment options, and mainly my specialty about the critical care management and about post-ICU care. Now, when we consider the epidemiology, this deadly virus has actually caused more than 477 million people to be deceased with this illness. And it has already killed more than 6.1 million worldwide. And USA is having the highest number of deaths and highest number of cases reported. Next is India, and then comes Brazil, France, and UK. Sri Lankan situation, we have had about 660,000 cases so far. These are only the confirmed cases. We have been having more than this. So far, about 16,000 people have died. This is how the waves have been in Sri Lanka. We have had about 3 big waves in the country. Now we are in this situation and in a sort of stable situation when we consider the statistics. Variants of concern have been several. In 2020, there had been alpha, beta, and gamma variants, but then came the Delta variant from India from October 2020. Now the commonest variant that we discuss is Omicron, and this Delta and Omicron variants have been very contagious, and Omicron variant is known to cause milder disease than other variants. So rather than going to more details about this virus, I will go to the disease spectrum in COVID-19. So when we get infected, the incubation period differs from up to 14 days. It depends on the variant type, and it is averagely 3 to 5 days. Most patients are asymptomatic or pre-symptomatic. So a confirmed patient with COVID-19 is a person who is test positive with a nucleic acid amplification test or an antigen test. But asymptomatic patients will not have any symptoms, but this is the majority. Then comes the mild illness. They have various signs and symptoms, mild symptoms with fever, sore throat, cough, malaise, some present with vomiting and diarrhea, but they don't have shortness of breath, dyspnea, or abnormal chest imaging. So this category, asymptomatic or mild illness, is up to about 80% of the population who get infected with COVID. Then the symptoms, cough is the commonest reported symptom, then fever and myalgia. Sore throat is about 20%. Loss of smell and taste is reported, but it is less than 10%. Moderate illness is when they show evidence of lower respiratory disease during clinical assessment or in chest X-ray or CT imaging. But these patients tend to have oxygen saturation above 94. Severe is when their saturation drops below 94 on room air, and when PaO2 to FiO2 ratio is less than 300, or when SF ratio is less than 235. And when these patients become tachypneic with a respiratory rate more than 30, or when they have lung infiltrates in imaging chest X-ray or CT more than 50%, we call them to have severe illness. And these severe illness patients can progress into respiratory failure, septic shock, and multi-organ failure, resulting critical illness. So you can see the 3 stages of the illness. Initially, you have the viral response and lymphocytopenia in blood. And then you go into the second stage, which is the pulmonary phase with abnormal chest imaging, and then hyperinflammatory stage. So in stage 1, you have the symptoms and lymphopenia. Stage 1, 2 is divided into 2A and 2B. Patients become breathless. And in the 2B, we see the hypoxia mainly. And we will see abnormal imaging, transaminitis and other abnormal investigations, especially in stage 3 when patients go into inflammatory response. We can see high CRP, LDH and interleukin-6, D-dimer, high ferritin levels in this stage because of the cytokine storm and inflammatory response of the patient. So the investigations we routinely order are full blood count, CRP, liver enzymes, and metabolic profile with creatinine, blood urea, and electrolytes. And chest X-ray is a mandatory investigation in these patients on admission and repeated as patient goes on with the clinical condition. Lung ultrasound, if available, especially in ICU setup, and we need a baseline ECG. We ask for special investigations like troponin, procalcitonin, ferritin, D-dimer, LDH, CPK, and BNP because we go for risk stratification. When these investigations show high values, when especially D-dimer is high, LDH or troponin, ferritin are higher than normal range, we have a clue that this patient could deteriorate and this patient could go into severe illness. So imaging wise, we see consolidation or ground glass opacities in peripheral areas in the chest X-ray. And HRCT is an investigation that should be done if available, and especially in severe category and ICU category patients. So these patients show ground glass opacification with or without consolidation. Lung ultrasound gives us clues about consolidation, about the fluid status, B lines, and nodular consolidations, and so on. So it's a point of care test if it is available. So when I move on to the treatment, actually the main treatment of this illness is oxygen, because it's a disease that causes hypoxia or type 1 respiratory failure. So when these patients present to wards, they get admitted when they are having moderate illness, mainly with symptoms, but they may be having saturation above 94. Still, if the work of breathing is high, and if they are deteriorating into severe illness or having chest X-ray features, bilateral chest X-ray features, more than 50% involvement, then giving oxygen is recommended depending on the patient's condition. So we can start oxygen therapy with nasal cannula 2 to 4 liters. Then Hudson mask, these are not the fixed compliance devices. These are low flow devices of oxygen therapy. Then you can move on to fixed performance devices like Venturi from 24 to 60%. Then if the patient is still not improving with 60% Venturi, we recommend to go to non-rebreather mask. This is a mask with a reservoir bag. I think it is the COVID era that introduced this mask to Sri Lanka, so which is very useful for patients who are deteriorating. So it's again does not fit properly, so the delivered oxygen concentration could vary depending on the fitting of the mask. So FiO2 can be 0.85 to 0.9. So we have to give maximum flow rate to NRBM, non-rebreather mask, that is 15 liters per minute. So these patients, as I told you all, it can vary the disease severity from mild, moderate, and severe. Mild patients can be managed at home. Moderate, yes, you have to get admitted. Severe category is what I'm mainly emphasizing, who need oxygen and then high flow devices and non-invasive ventilation followed by invasive ventilation. So after oxygen therapy, what is the most important treatment we talk about? That is steroids. So dexamethasone, studies have proven the effect of dexamethasone, mainly the recovery trial. But when we go through the results of the trial, we have to use dexamethasone in severe category patients who are oxygen dependent or patients who are on invasive ventilation. So the mortality, there is a benefit when in the arm that has been on dexamethasone. But the patients who did not receive oxygen, that is the mild category of this disease, have had higher mortality due to dexamethasone. So this is an important thing about steroids, because steroids can be useful as well as harmful. So our Sri Lankan guidelines recommend dexamethasone 6 milligram per day, oral or IV for 10 days, or until hospital discharge for patients who require oxygen. Mainly the severe category patients will benefit. If dexamethasone is not available, you can give the equivalent dose of oral prednisolone, oral methylprednisolone, hydrocortisone. For gynae and obs patients, so we have to consult the relevant consultant for the management with steroids. We did a study, observational retrospective study in our deaths in Kandy ICU, COVID ICU. We analyzed 79 deaths, and actually most of the patients were on steroids, and we noticed higher proportion of bacterial co-infection in patients who were on high doses of corticosteroids. So that is one harmful effect we have noticed. Then after oxygen, steroids, next comes anticoagulation as one of the main treatment arms. So venous thromboembolism prophylaxis is recommended in all severe category patients. The recommended dose in an average person is 40 milligrams subcutaneously once a day. The dose depends on the creatinine clearance. If the patient is in renal failure, if the creatinine clearance is less than 30, it is recommended to half the enoxaparin dose, or you can switch to heparin 5,000 units subcut twice a day. Then if the patient is having proven thromboembolism features in a CTPA Doppler scan, or if we have clinically high suspicion, if we have a D-dimer level above 1,500, we move to the therapeutic dose of the enoxaparin, that is 1 milligram twice a day or 1.5 milligram per kg once a day. Again, if the creatinine clearance is less than 30, we will reduce the dose to 1 milligram per kg once a day. Previously, in the initial phase of the COVID management, we used to give treatment dose to all patients. There were studies that compared the two arms, prophylactic and therapeutic, and there were no benefit. Actually, there were harmful effects noticed in the therapeutic arm. So now it is not recommended unless we have clinical reasons to give a therapeutic dose. Other than oxygen, steroids, if in patients who necessary steroids and anticoagulation, other most important part of the management in COVID patients is fluid. Now, these patients, when they come to hospital, they are usually dehydrated. They have been ill. They have not taken enough orally. So they are in a deficit of fluid, and we should replace their fluid deficit, or else we promote them to go into acute kidney injury. So initial phase, when the patients are in wards, please make sure that they are well hydrated, at least 2 to 2.5 liters per day. They can take orally in mild to moderate disease category. So oral fluids should be well recommended in the initial phase. But when it comes to severe and critical illness, then we are a bit careful with fluids, and we always monitor the capillary refill time, urine output. We want to maintain output more than 0.5 ml per kg and lactate less than 2. And we always continuously assess the fluid status with ultrasound, echo, IVC, and we do the passive leg raising test as well. So other treatment options, I will quickly go through these novel drug therapies that we have been using. Interleukin-6 receptor antagonist use, there has been proven benefit of giving interleukin-6 receptor antagonists like tocilizumab or saralimumab to patients who are critically ill. And for the recommendation, the dose is 8 milligram per kg, but this should be given to recently hospital admitted patients and those who need ICU care and within 24 hours of admission to ICU, and when they have high oxygen requirement, rapid increase in oxygen requirement. And we also check the CRP level, it should be more than 75 or doubling over 24 hours. And we have to be careful in giving tocilizumab because certain patients are contraindicated when they are immune suppressed, when they have active TB or herpes zoster, and when the procalcitonin level is more than 0.5, or when neutrophil count is less than 500 or platelet less than 50,000, or alanine aminotransferase more than 5 times upper limit of normal, we don't give tocilizumab. Then the antiviral therapy famously given is remdesivir. In NICE guidelines, it is recommended to give it up to 5 days in adults and young patients above 12 years. And NICE guideline also recommend not to use it in patients on high flow oxygen devices. That is, when they are going into critical phase, it is not recommended. This is a drug that is recommended in the early phase of viremic phase of the illness. And it was the study proven this benefits was ACTT1 trial. Then this monoclonal antibody combination, casirivimab and imdevimab, in US guidelines, NIH guidelines, they recommend this combination of monoclonal antibodies for patients who are immune suppressed for post-exposure prophylaxis. But in NICE guidelines, now they recommend it to give these monoclonal antibodies to patients who have no low level of antibodies. They screen the antibody level and give it. We don't have it freely available. This is very expensive. Then when the patient becomes critically ill, first we admit these patients to our high dependence units where the oxygen therapy is escalated to high flow nasal oxygen. This is the high flow nasal oxygen device. This can give 60 liters per minute oxygen. And this will use up more than about 6 jumbo cylinders if you are using through a jumbo cylinder. So you need all oxygen for this device. And other non-invasive method we use is Cpap or bilevel through non-invasive ventilation. So the current evidence for which type of non-invasive ventilation, high flow or Cpap or BiPAP, in one of the recovery arms, they checked which reduced the incidence of tracheal intubation. Actually, Cpap compared to high flow and conventional oxygen therapy has reduced the need for intubation. So if you have the options, going for Cpap or bilevel is better than going for high flow or conventional oxygen therapy. So when you are giving NIV, we have to be careful what to use. Now, these NIV masks should be well fitted, and it should be a non-vented mask with this solid elbow connection, blue connection, and we have to use a viral filter. Now, if it is a single limb circuit, we have to have a leak port so that the expired air is leaked out. Or if you are using a dual limb circuit, then it's all right, we don't need a leak port. Then or else you have to have an exhalation valve. So these patients who are on NIV or high flow devices in HDU setup, we recommend them to do awake prone ventilation. As patient tolerates to change the position of their stay every 2 hours. And this improves the oxygenation. When patients deteriorate while on high flow or NIV, then the patient is referred to ICU care. So when there is severe hypoxemia or when refractory circulatory shock or multi-organ failure, they refer the patient for ICU care or level 3 care. But we have to make sure that these patients have adequate physiological reserve to survive a critical illness. and we have to make decisions about escalation and organ support. Especially elderly patients, patients who have comorbidities like diabetes and hypertension have proven to go for more critical illness and complications. And patients who have chronic respiratory illness, renal failure, liver or cardiac illnesses also prone to go for critical illness. Other parameters are these investigations I spoke about previously that they also give us a clue. So there are certain exclusion criteria for accepting a patient for ICU, especially when the frailty scale is more than 6, or if you have severe comorbidities with life expectancy less than 12 months, we don't go for ICU admissions, but we have to decide on ward-based care. Then one important category in patients with COVID illness is self-inflicted lung injury. So this is a controversial concept, but we see lung injury in patients who are on spontaneous breathing as well, assisted or unassisted. So while on assisted ventilation, non-invasive ventilation, high flow, or without any ventilatory support, we see patients developing pneumothorax, pneumomediastinum commonly in COVID patients. So we go for invasive ventilation. One reason is to prevent or reduce this high transpulmonary pressure and to minimize the self-inflicted lung injury. And when we cannot maintain oxygenation above 92% with other methods of non-invasive ventilation, we go for invasive methods of ventilation. So in invasive ventilation, one important aspect is we go for lung protective ventilation. And according to the ARDS net protocol, we go for 6 ml per kg ideal body weight. And our ventilatory settings can be volume control or pressure control depending on the preference of the intensivist or anesthetist. And we have to maintain safe pressure limits, driving pressure less than 15 and plateau pressure of less than 30. Our target saturation is 92 to 96. If it is a compromised lung patient like COPD or chronic lung illness, then we go for 88 to 92. And our target partial pressure of oxygen is only 60 in this type of patients. And we maintain deep sedation, paralysis as necessary. We go for inverse IE ratio, allowing hypercapnia, permissive hypercapnia, and we go for high PEEP ventilation in ARDS type 2 lungs, which has low compliance. And we consider early prone ventilation, and we do continuous monitoring and fluid assessment with echo. If the patient is not improving with these, we have to refer for veno-venous ECMO. About prone ventilation, why do we recommend prone ventilation? Usually in supine position, you can see that dorsal lung is atelectatic, and there is a VQ mismatch in supine position, which can be corrected with proning. And this atelectic dorsal part is opened up when we prone the patient. So this is a difficult procedure and they need skilled people, but we don't have any instruments to do this. We do it as the Cornish pastry method. We sandwich the patient in between bed sheets and we move the patient. We need at least 5 people to do this. One person at the airway end who should be airway trained doctor. So once the patient is prone, we go for extended proning in COVID. Usually it is 16 hours. We can go for extended proning in COVID, and we have to change the head position and the arm positions every 4 to 6 hours. Other management include prevention or continuous management of AKI. So once the patient establishes AKI and with fluid management, if we cannot reverse it, we might have to implement renal replacement therapy with continuous renal replacement or intermittent or sustained low efficiency hemodialysis. And these patients commonly get high troponin and myocarditis features, arrhythmias. So we have to continuously monitor and maintain electrolytes like magnesium and potassium in the normal range. And depending on ECG troponin features, we go for 2D echo and cardiology input. Some patients have high transaminases, but we don't see major liver failures in this type of patients. And glycemic control, we go for 140 to 180 milligrams per deciliter. And we need very good nutrition in these patients because they go for long ICU care. And sometimes these patients develop encephalopathy, seizures, and ICU delirium is common in these patients. What is the place for antibiotics in COVID-19? It is not a drug to be given routinely. But you can consider giving antibiotics if there is clinical suspicion. like purulent sputum in ET secretions, or leukocytosis with neutrophil toxic granules in blood picture, rising CRP, OPCT, or if there is evidence of blood culture, sputum culture positivity with with microbials. So the multidisciplinary team response is important here with the microbiology input for antibiotic treatment. Sri Lankan guidelines recommend to give ceftriaxone with or without azithromycin or clarithromycin in moderate severe bacterial pneumonia, but with severe, they recommend carbapenems or other drugs like piperacillin, tazobactam. In ICU patients, we see multi-resistant organisms, as I mentioned before, and we see Acinetobacter as one organism that we see commonly. And in the 79 deaths we analyzed, one thing we noticed is empiric carbapenem use was high compared to the incidence of bacterial co-infection. So the patients usually come to ICU with meropenem started, so we can't stop it as well. But so we have this problem of antibiotic stewardship currently in our setup. So when we talk about critically ill patient management, one most important thing is staff protection. So previously we used to wear this 3-layer kit from head to toe, which is not necessary anymore. According to the CDC guidelines, our face needs only a NIOSH-approved N95 mask with a goggle or face shield to cover the eyes, then the gown with long sleeves, and one pair of clean non-sterile gloves. We don't need shoes or boot covers. So this is enough to manage a critically ill patient. So one problem we had in managing ICU patient was this PPE. It was very obstructive for optimum patient care. So now actually staff can rely on this and manage patients with this minimum personal protective equipment. Other important aspect about managing severe category or even moderate category patients is when they come with COVID, they are scared of death. Then they come to our ICU, they are really scared that they will die. So we have to speak to the patient, reassure the patient. Patient psychology is very important for patient survival and improvement. So we have to uplift their psychological aspect. So speaking to their family and supporting their mental well-being, making the surroundings suitable for them is very important in the management. This includes staff as well. Managing COVID patients is very stressful to the staff. Then one word about post-Covet syndrome. After about 1 month of illness, these patients suffer from various some of the patients, not all, suffer from various symptoms like fatigue, declining in quality of care, shortness of breath, persistent oxygen requirement. ICU patients, we see them with critical illness, myopathy, post-traumatic stress syndrome, depression. So these patients need psychological support and rehabilitation mainly to come back to their normal life. It might take months, about 3 to 6 months for them to come back to their normal life if they suffered from critical illness myopathy. So physiotherapy and pulmonary rehabilitation is important. Some patients we have discharged home with oxygen concentrators. They have successfully weaned and now most of them are off oxygen after about 3 to 6 months. And nutrition is also very important for their recovery. So these are my references on this presentation. So I think we have gone through a storm, and the best thing about storm is that it should come to an end. I hope it will be as calm as this sea and we won't see another wave of COVID. Thank you.
Thank you very much, Abudhini, for that elaborative lecture. We next move on to the next lecture. It's my pleasure to introduce Dr. Anuma Siribardana. She is a trainer of most of us, a teacher of most of us, respiratory physicians in this central province, and has been probably an icon of respiratory medicine development in the central province. She has been the founder of the Postgraduate Training Center in Respiratory Medicine in Teaching Hospital Kandy, and has been a past president of the Kandy Society of Medicine and a founder president of the Sri Lanka College of Pulmonologists, and has been a founder member of the SARC Association of Thoracic Sciences and Southeast Asian Academy of Sleep Sciences. It's my great pleasure to welcome Dr. Anama Silvathan to give her lecture on sleep-related breathing disorders. Over to you, madam.
Thank you very much, Manil, for the kind words of introduction. Now, why do we need sleep? Now, Mahatma Gandhi, the great Indian politician, once told that he dies every night when he goes to sleep, and he's reborn in the morning as a new person, so that he faces the challenges of the day as a new person. So how does this happen? This happens because sleep is essential, and it's essential biological function, and it plays a major role in recovery and energy conservation and survival. You can't survive without sleep. And it's important for all the vital functions: neural development, learning, memory, emotional regulation, and cardiovascular and most of the metabolic functions, and removal of toxins, as well as, so we know that good quality sleep is critical for good health. Now, what are the things which will hamper good sleep? They are called sleep-related disorders. And then the primary disorders are called dysomnias. And they are the commonest would be, I say, insomnia, where people find it difficult to breathe, difficult to sleep. And hypersomnias, and narcolepsy is the extreme form of hypersomnia, where you can go into REM sleep at any given time. And then we have the circadian rhythm sleep disorders, and another large group of category of breathing disorders, breathing disorders related to sleep. So we call them breathing related sleep disorders. And when you go into them, the commonest would be obstructive sleep apnea, and it is about 85% of all the sleep disordered breathing disorders. And we have central sleep apnea, which is not as, it is about 10 to 12. And kinds of breathing, again, it's sleep-related breathing disorders, especially we see them in people with severe left ventricular failure. It's a form of central sleep apnea. Now, here, Malin gave me this slide. Now, the person who is sleeping well is the patient. Is there a pointer here? Right, so the patient is sleeping and snoring away, and the sleeping partner, the partner here is she's very disturbed, and then she's trying to close her ears because the patient is snoring. So this is another problem that we encounter in sleep patients, where the bed partners are finding it very difficult to cope up with this. Right, so basically this is what happens commonly. This is the commonest form of obstructive sleep apnea, where now you see this, the airway here is sort of a muscular tube without any bone support. And then in sleep, when you go to sleep to facilitate sleep, all the muscles will relax, and the muscles of the pharynx, the constrictors, the denucleosi, the muscles will relax, and then this will lead to obstruction of the airway. Here you see it. And then when it is getting obstructed, the patient will snore, keep on snoring, and then when it's completely obstructed, you get cessation of airflow. If there's total cessation, you call it apnea. And if it is more than 50%, you call it hypopnea. And then between 30 and 50, you call it rara. I'll come to that later. So this recurrent closure of the airway, this is the commonest form of obstructive sleep apnea, will lead to this. When the airway closes, the efferents from the upper airway will send impulses to brain. Now, see, you are stopping breathing. Please wake up and breathe. So that each time this happens, the brain wakes up, the sleep is being disturbed, and then you are not going to get a restful sleep. So it's a problem. Now, how many times that this happens per hour is, we say it's a apnea hypopnea index, and we see patients who are having more than 100 in our setting, more than sometimes 200 sleep disturbances per hour. That's severe sleep apnea. Now, so this is what it's a cartoon saying that this is the apnea fairy is causing apnea, and your sleep is being disturbed at 10:30, 10:47, 10:54. So likewise, the sleep is being continuously disturbed. This is the rather common phenomena that we see every day. Now, what are the consequences? So what happens when your sleep is being disturbed? One thing is that the sleep is fragmented and then you are not getting adequate sleep. And consequently, when the upper airway closes, when there's apnea or hypopnea, there will be hypoxia and hypercapnia. That also is happening. And all that will lead to sleep fragmentation. This will lead to, when you are not having adequate sleep, the next morning when you wake up, you will be very sleepy and you will be very grumpy. Your mood will change. You are not ready for the day because in the morning you will be very sleepy. And then due to the chronic hypercapnia, you might be getting headaches. Actually, it is not only due to hypercapnia. In the early morning headaches are a common complaint that our patients tell us. And then due to the recurrent awakenings, there will be very significant serious cardiovascular complications. And this lead to very much increased morbidity and mortality, where most of our patients, it's very difficult to convince them. And this is all evidence-based that in the cardiovascular mortality in severe obstructive sleep apnea will go up to about 50% due to the presence that the patient is having, due to the fact that the patient is having obstructive sleep apnea alone. It's an independent risk factor for most of the severe needs. So that the consequences, now there are two arms. One thing is that you are sleepy in the morning, and on the other hand, that there are the cardiovascular complications. And it has been in about 10 years ago, it was said that more than 50% of the accidents, road traffic accidents, fatal ones happened in UK were due to obstructive sleep apnea. So that increased motor vehicle crashes when people are falling asleep when they're driving, and then increased work-related accidents. So carpenters, engineers, people who are working with tools, they might fall asleep on their tool. So it's very important. And then due to this unrefreshed sleep, poor job performance, people get depressed. There's family discord, and there's nocturia, and then decreased libido. So that is again a big problem where mostly the wives come and complain. And overall, there's decreased quality of life due to this poor sleep. And you see this cartoon, again, Mari gave me this, shows that the consequence of your lethargic, unrefreshed sleep, and then you have, you are not fit as Mahatma Gandhi to face the challenges of the day due to this sleepiness. And these are very, very serious, the cardiovascular consequences. Now, systemic hypertension, OSA per se is an independent risk factor. If we are having more than 3 classes of antihypertensives, whether the person complains of daytime sleepiness or not, you have to carry out a sleep study because it is important. And cardiac can have fatal cardiac arrhythmias leading to sudden cardiac death in OSA, and myocardial ischemia, ischemic heart disease. It's an independent risk factor for ischemic heart disease, left ventricular failure, strokes, pulmonary hypertension for pulmonary, of course we know. And then now the newest thing is NASH. People with sleep apnea can lead to non-alcoholic steatohepatitis. So, and poor control of diabetes mellitus. So it's again, if you're diabetic patients, sugar control is inadequate, there's an indication to do a sleep study. Right, so how does this happen? So one thing is that when the sleep is being disturbed all the time, there is, when you are waking up, there are hydrocortisone surge, the catecholamines, adrenaline and noradrenaline, there's a surge, this is a circadian rhythm. But when it is happening throughout the night, there is all the time when the patient is awakened, there will be this sympathetic activity. So there will be a hypersympathetic state throughout your day. And then it's shown that there is endothelial dysfunction. It's very important in cardiovascular health. So as indicated by the reduced serum nitrous oxide, and it is a hyperinflammatory state. There is high oxygen radical production by leukocytes, and TNF alpha is increased, and there's increased coagulability, and it is due to the fact that the patient has sleep apnea per se can lead to increased CRP. So it's a hyperinflammatory state. Now, when a person comes to you with a sleepy person with snoring, before you come to this diagnosis of obstructive sleep apnea, you have to be looking at the upper airway anatomy. Is there any anatomical problem or a structural pharyngeal lesion which is correctable? So you have to have a thorough evaluation on the upper airway, look into the throat, and then you may go for imaging or lateral soft tissue X-ray of the neck and so on to see whether there is anything correctable. But mostly it is not, but you have to do it. And then we see plenty of people with hypothyroidism, and acromegaly is not that common, associated with sleep apnea. So TSS screening, basic screening is a must in all patients who are excessively sleepy. Now, then the neuromuscular weakness, not common, but you have to look for it. And then pharyngeal infiltrations with obesity, with mucopolysaccharidosis. So those are rare, but still these are structural lesions that obstruct the upper airway where you have to be mindful of. Now, what happens during an apnea? When the airflow ceases at the onset of the apnea, there is bradycardia and hypotension. And then the apnea terminates. When the patient wakes up, there will be tachycardia and hypertension. So this happens throughout. If there's an hyperapnea index is 30, this will happen 30 times an hour. There will be bradycardia, tachycardia. So this is very detrimental to the cardiovascular health. Right. So when a sleepy patient comes to you, what do? You initially assess the patient, and then you assess the patient and decide whether you are going to do a sleep study or not. And then you come to a diagnosis. The best way to diagnose would be do a sleep study, but clinically you can suspect. And then if the patient is very sleepy, even without a sleep study, you can go ahead with the treatment, but you have to have very good clinical foundation for that diagnosis. The gold standard would be to carry out the sleep study. Now, so this is the initial assessment. And again, when the patient is sleepy, please go into the details of his sleep. Is he getting adequate sleep? Is the poor sleep hygiene? Is he going to sleep with the lights on, with the computer on? So that is important. I mean, most of the teenagers, they go to sleep with their devices on. They want to look at the Facebook. So that is one reason why they are sleepy in the morning. And then depression, again, will lead to sleepiness, inadequate sleep. And this very interesting disorder called the periodic leg movement syndrome, we see quite often, where this also, people will move their legs, will be again sleepy during the day. There will be awakenings due to the periodic limb movements. And narcolepsy, of course, that we see people sometimes people who are another disorder where you will go into from the alpha rhythm, awake rhythm, you will go to REM sleep instantly. So that is a rare disorder, but still we see in sleepy patient. Right. So how do you assess sleepiness objectively? We use the Epworth sleepiness score for that. It's very simple. And it is that you give a scale by 0 to 1 or 0 to 3 in these situations. We give 8 situations: sitting and reading, watching television, and then sitting in active public place, and passenger of a car. And then this is most dangerous is that when you are stopping your car for traffic lights, would you doze? Would you go to sleep? So these 8 situations, what is the likelihood of you going to sleep? So then you give the score. If it is 1 to 6 is good, 7 to 8 average, but 9 and up, we have to arrange a sleep study. And then we have the stop bank questionnaire, again a very easy as questionnaire, as clinically assess, and then see how severity, the overall condition, not on sleepiness, but the overall obstructive sleep apnea syndrome, and then how soon that we should be evaluating the patient and putting the patient on treatment. So the stop bang is STOP, snoring, tiredness, observed apnea by the bed partner. If the person says sleeping with the patient, that this person snores and then stops breathing for some time. A beautiful prescription is given in Anna Karenina, the book by the Tolstoy, where Anna describes her husband Alexandroi having sleep apnea. That book is written in 1880s. So that's been described very beautifully, the observed apnea. And the blood pressure, if you are having high blood pressure, again, you have, it is important to note that you have to get a sleep study early. Bang B for body mass index. And here we consider 27 as more than 27 as significant, but we have people with body mass index of 54 even last month. We have lots of obese population. And if it is age above 50, the next size will give an indirect measure of the central obesity, and the gender, male gender is more prone to get sleep apnea. So that if you get marks for this, again, this will tell us how soon that you should be evaluating the patient. And then combining the Epworth and the subband, we have the Berlin Sleep Questionnaire. You can go into the websites and then you can get it. It's still also a good clinical assessment. Now, then we assess the patient for sleep studies. We can do a diagnostic sleep study to diagnose. And then if you're going to give Cpap, you can do what is called Cpap titration, where you have to find out the optimum pressure to be applying in the Cpap. But now we don't have to do this anymore because there are machines, autopack machines, which will be, the machine itself will detect the resistance and then what is the optimum pressure to be delivered to the upper airway to keep it open. So that you don't have to do this anymore, but still it's a good practice if you can do it. And a split night. Now this is where this is by law in America. So if you are by 12 o'clock at night, if you are detected this patient is having sleep apnea and severe sleep apnea, that means AHI, that is apnea hypopnea index of more than 30. So there are sleep disturbance per hour, 30 disturbances. So that is, they consider this is an emergency. So you have to give Cpap. So that is a split night study. So by law, so if the HI is about 30, it's a life-threatening condition. So that's what is meant by the split night study. And then you can do the sleep latency tests mainly for insomnias and the maintenance of wakefulness test for these people who are having narcolepsy and so on. So these things can be done. And then how do you sleep? Now we have to stage the sleep. Level 1 sleep study will be giving you EEG and will be telling us what is the level. Now as you know, the level would be the non-REM. When you go to sleep, you go into non-REM 1, 2, 3, and then you go to REM. So the sleep study will stage your sleep. And then if there is sudden reversal from the slow waves, from the delta waves, which you get in REM, delta, and then the theta waves, these high amplitude slow waves, and there's a sudden reversal back to the alpha rhythm, you know that there's an awakening. So this EEG will tell us, now this is an arousal. And then in respiratory events are the apneas and hyperapneas, whether there is cessation of the airway and upper airway resistance. Now this is rare, where there is not much of a problem of airway obstruction, but this will lead to, the RERA would lead to awakenings. So these are significant events. So HI plus the RERA will be giving us the RDI, the respiratory disturbance index. Then the limb EMGs will tell us the periodic limb movements and the restless legs. So these are some of the parameters. So these sleep stages, you know, light sleep stage 1, and then stage 2, stage 3, and then you go into REM sleep, which is very important for learning and memory. And in children, now small children will spend most of their sleep in REM sleep. Neonates will spend about 22 hours a day in REM sleep, as that is very important for learning and memory. But when you grow old, the amount of REM sleep will be reduced. But REM sleep, where there's total body atonia to facilitate sleep, and the mind is very active during REM sleep, where you have vivid dreams during the REM sleep. Right. So that the respiratory events, there's obstructive or central. Now, central will be where the respiratory centers will not be sending impulses to your breathing muscles, namely the diaphragm and the intercostal muscles, so that you don't breathe. And mixed, we see mixed apneas when there is commonly, there's a mixture of this. And then hypopnea, where that is hypopnea, again, not total cessation, but more than 50% cessation. And the RERA, they are very important, RERAs. Now, that is, there is not, there it is less than 30%, less than 50% of whole obstruction, but that is associated with the arousal. The upper airway resistance will be leading to sudden comeback to the alpha activity. So, this causes, and the amount of RERA is something that is, most of the sleep machines are missing that, but it is very important. Right now, here we see this is the oral, this is the respiratory epoch of a sleep study, where there is, you see, this is a total cessation of airflow here. This is an apnea. And then this is the thoracic movement. You see the movements are there irrespective of the cessation of the airflow. And then this is an awakening, where the patient is suddenly waking up and there is sudden increased work on the thoracic muscles and thorax and the abdomen. So this is an awakening here following the apnea. And then here you have the following the apnea, you have the hypoxia. And then once the patient awakes and starts breathing, oxygen picks up. Then here, this is the microphone which picks up the snores. The patient's nose keeps on snoring, and then there is total cessation, no sounds, and then again the snore starts, and then again will lead to this apneic episode. So that this is a typical respiratory epoch of a obstructive sleep apnea. In central sleep apnea, you will see this cessation, but again here there won't be any thoracic or abdominal wall movements. Again, there's a flat line because the respiratory centers are not sending impulses to the respiratory muscles. So that is a central apnea if this is a flat line, but this is the commonest form, the obstructive sleep apnea. And then you will see the corresponding hypoxia, hypercapnia in which other tracings, as well as the hypotension and hypertension, and then bradycardia followed by tachycardia in corresponding to these apneic events. Right. So what are the treatment options? This is very, these are things that most people are obese, so weight reduction, posture training to sleep not supine, but to sleep prone onto a side, and then avoid alcohol, sedative, smoking. And there are oral appliances to keep the jaw advanced, to keep the behind the tongue, that area wide. And then jaw advancement devices can have the jaw advanced so that the posteriorly you have enough space in the upper airway to be breathing. And then palatal surgery, now you can do this. Initially a thing called UPPP, palatopharyngeoplasty was done, but now it is not done anymore, where some of the palatal structures are being chopped off to create more space. And then mostly and most importantly, the Cpap. Now Cpap, we know Cpap, a continuous positive airways pressure. We use that now mostly in type 1 respiratory failures in the ICUs. But it was initially, it came for OSA in 1980 by Professor Sullivan. It creates a pneumatic splint in the collapsed upper way. It's like that. When the upper airway closes, this lead into the upper airway. It's like an air compressor. The air column will not allow the upper airway to collapse and keep it open by this pneumatic splint, so that you have to find out the minimum pressure to be applied. You can't be giving about 20 centimeters water pressure. The patient did not be able to sleep. So you give the minimum pressure to keep a comfortable sleep. So that is what is meant by sleep titration, but the machine will do it for you. Right. So this is a person who sleeps with the CPAP machine on, and the effects of CPAP are many. All these are randomized RCTs. It will reduce respiratory disturbances, and this all that is right. So that is, it improves blood pressure, improves the diabetic control, and so on. And this again, improving quality of life, will improve the total personality, the mood, and the all intellect, and the blood pressure improvement with CPAP, reduction of medication use, and diabetic severity, how it improves, reduction of the medication use and reduction of hospital admissions, and depression, anxiety, and mental health problems, improvement with CPAP. So all in all, sleep apnea is common. It's dangerous. It can kill. It's easily diagnosed, and but it's treatable. And everybody needs sleep. Thank you very much for your kind attention. Thank you.
Thank you very much, Madam, for a very clear lecture. Reminds me again how successful you have been as a trainer and a teacher. I think due to the interest of time, unless there are any burning, it's probably wrap the session now. If there's anything, any burning queries, we have time for one question. All right. In that case, since we have to stop at 10, we'll wrap the session.
Thank you, sir. That concludes the Respiratory Symposium. I'd like to invite our chairperson, Dr. Manil Piris, to give away the token of appreciation to our resource persons. Dr. Amila Ratnapala, Consultant Respiratory Physician, National Hospital, Kandy. Dr. Abudhini Bhulpitya, Consultant Intensivist, National Hospital, Kandy. Thank you, sir. Now I invite Dr. Damit Nandadeva to give the token of appreciation to Dr. Anoma Siripaddana, Consultant Respiratory Physician, National Hospital, Kandy. Next, I invite Dr. Harit Vimalaratna, Senior Consultant Physician, to give the certificate of appreciation to our chairpersons today. Dr. Manil Piris, Consultant Respiratory Physician, District General Hospital, Matale. Dr. Damit Nandadeva, Consultant Respiratory Physician, General Hospital, Monragal. Thank you, sir. That concludes the Respiratory Symposium.
Thanking the chairpersons and the speakers of the Symposium 1, we are now moving on to the keynote address of the 44th Annual Academic Sessions of the Kandy Society of Medicine. Let me invite the two chairpersons for this session, Professor Manjula Atigala, President of the Kandy Society of Medicine, and Dr. H.J. Suravira, Senior Consultant Orthopedic Surgeon.
Good morning. It gives me great pleasure to introduce our keynote speaker today for me and also to Professor Manjula Artikala, the president of the Candy Society of Medicine, joins with me to introduce this keynote address speaker. He's not a stranger to this audience, but as a protocol, let me introduce him. He's my dear colleague, friend, Dr. Sunanda Udagedara, senior orthopedic surgeon from National Hospital, Kandy. Sunanda is a product of University of Ruhuna. He graduated in 1989 and he obtained his master's degree in 1998. And he became a consultant orthopedic surgeon in 2001. And then he served as a consultant in Mathura. And then he joined the National Hospital Kandy in 2004. And since then, he had been working in National Hospital Kandy. And his contribution to the orthopedic academic activities as well as the other services are immense. Currently, he is the senior orthopedic in charge of the Kandy National Hospital Kandy. And as well as more importantly, he is the chairperson of the Board of Orthopedic Surgery at the PJ Postgraduate Institute, Colombo. And also he was the past president in Sri Lanka Orthopedics Association in 2018. And he is an examiner and also affiliated member of American Orthopedic Association as well. And he has conducted many lectures, he has delivered many orations, but I'm not going to go through that. But I just want to mention a few things. He's the most senior orthopedic surgeon right now in this country, as well as he's the leading arthroplastic surgeon in Sri Lanka. And as well as he has established Center of Excellence in Kandy, the National Hospital Kandy, which is a pride for this region. And he has performed many arthroplasty surgeries, and he has trained many trainees as well. And of course, if you look at the joint replacements, globally, the numbers are, we are talking in millions, but numbers in Sri Lanka is maybe less still. If you look at this joint replacements, right now, the total hip replacement is considered as the surgery of the century because of its impact to the patients, how to overcome in the crippling problems and disabled problems and get the lifestyle back to normal. This is the impact, not only the hip replacement, the knee replacement as well. And Sunanda has got the authority to deliver this keynote address because of his experience in this arthroplasty field. I think he's the most suitable person right now in this country to deliver this type of lecture, to talk on Sri Lankan perspective and the timeline, how it has evolved, and also how the technological advancement has happened about this orthopedic intervention. May I invite my dear colleague, Dr. Sunanda, to deliver this keynote address. Thank you.
Good morning. Thank you very much, Dr. Suravira, for that lengthy introduction. And I must also thank the President and the Council of KSM for inviting me to deliver this keynote address. And the topic I selected was Chronicles of Total Joint Replacement in Sri Lanka. I'll be describing how the arthroplasty services started and evolved in Sri Lanka through my personal experiences. But I must mention that I'm not the only orthopedic surgeon who has gone through this journey. And I'm sure most of my contemporary colleagues, Dr. Suravira is definitely included, also must be having similar stories to tell. And therefore, I dedicate this talk to all those who got involved in the development of arthroplasty services in Sri Lanka to what it is today. So, replacement arthroplasty is where we surgically replace the damaged articular surface with synthetic components, and osteoarthritis is the most common indication for total joint replacement. And according to the WHO disease burden statistics, osteoarthritis is the single most common cause of disability among older adults, and prevalence of osteoarthritis is estimated among the people older than 60 at 10 to 15%, and successful restoration of functional disability of osteoarthritis victims has puzzled orthopedic surgeons for centuries. And finally, total joint replacements have evolved to be the most successful and cost-effective therapeutic intervention for osteoarthritis, especially of larger joints. And in this talk, I will be briefly talking about the osteoarthritis of hip and knee. That's where most of our replacements done in Sri Lanka. But of course, we also do replace shoulders and elbows, but I'm not going to talk about those things. And then how the total joint replacement started in Sri Lanka, and learning and teaching activities related to arthroplasty. And finally, my experience in total joint replacements in National Hospital Kandy. Of course, I will have one slide on future directions as well. So if you look at the knee joint osteoarthritis, this is how it would look like in an arthroscopic, nice articular surfaces, and this is how it looked like when it is destroyed. But radiologically, the disease starts with the mild narrowing of the medial joint space, mostly medial joint space, and then it progresses to bone-to-bone disease, and then start destroying the knee joint, medial side or lateral side or both sides it could be. And it is not uncommon to see this type of destruction as well. And you could imagine how an arthroplasty surgeon could restore the function of this joint that is seen in this picture, where there is no bony references and there are no ligament support in the knee. And now this is the type of clinical deformity that we see. And talking about osteoarthritis of the hip joint, most of the patients will come to us with when there's a simple joint line, joints space narrowing, but we do see patients with this sort of a severe destruction as well. And another fairly common disease entity we come across requiring arthroplasty is avascular necrosis of the head of femur. And then another uncommon but severely disabling pathology that we see requiring arthroplasty is protrusio acetabuli, where you can see this right hip, the hip joint is moving, migrating into the acetabulum, fixing the whole joint, making the patient almost crippled. And then history of surgical treatment of osteoarthritis. Before the 17th century, the orthopedic surgeons had various attempts at improving the functional status of the patient, such as joint fusions, arthrodesis, and various types of arthroplasties like excision, interposition, and the list goes on. I'm not going to bore you with all these things. And then in late 17th century, exactly in 1890s, Theophilus Gluck got the bright idea of replacing the entire joint. And then he manufactured his joints with ivory. And when this joint failed, many people blame the materials used for the failure. And then subsequently, many surgeons started manufacturing the similar designs using synthetic materials like cobalt chrome, which are used even today. But what they failed to understand was the mechanism of failure was not the materials used, and it is due to the design. This design was a hinge design where the femoral component was fixed to the tibial component in a hinge fashion, and it allowed only the hinge movement. But the knee joint, in normal knee joint, is not a pure hinge joint. So the orthopedic surgeons took nearly 1.5 centuries to realize that it did not replicate the normal knee movement. And then the era of total condylar knee designs were introduced, where the femoral component was completely separate from the tibial component. And there came a bigger problem for the orthopedic surgeons, because he has to balance the soft tissues so that these two components will be together to function as a joint. So soft tissue balancing became very important. So therefore, modern arthroplasty is not a bony surgery. It's a soft tissue surgery where we have to balance the soft tissues around the knee joint for it to function on a long term. So the first total condylar design was introduced by Insole and John Insole and his co-workers in USA in 1973, and it marks the beginning of the modern total knee arthroplasty design. The first total knee arthroplasty in Sri Lanka was in a private hospital in 1987. And in a government hospital was in 1994, almost 3 decades after the introduction of this technique. And I was fortunate enough to be a medical officer in that unit. I will come to that surgery in a next few slides. And then the surgical techniques and instruments did not stop there. John Insole's design was a very simple design in terms of instrumentation, surgical common sense, and simple eyeballing to align the component on the bones were the main guidelines the surgeons had. But then the importance of proper alignment of the component on the host bones and proper rotations and ligament balancing is absolutely important. So to aid in that, more and more designers introduce more and more instruments. And finally, there were a lot of instruments that we have to use during arthroplasty. So stop moving, sorry. Okay, now, for example, the modern total knee replacement instruments that we use in Kandy and most of part of the Sri Lanka has 7 boxes of instruments, and each box will have 2 or 3 trays of instruments in it, and each tray will have a set of instruments for specific step of the procedure. So we have to assemble all these instruments taken from each tray and then adjust them according to the requirement of the patient, and the procedure has to be done. You can imagine how, if you don't know, I mean, any monograph will describe these surgical instruments by name, as you have to know the name of the instrument, and it's a bit of a complicated surgery. But then history of total hip arthroplasty was not that far back, and it started as a partial replacement, which is we call hemiarthroplasty, and done by Dr. Austin T. Moore. And in 1940s, Austin Moore design is still used in many parts of the world, including Sri Lanka. But this design of hemiarthroplasty is only suitable for replacing only the head when the head is damaged or vascular, where the acetabular side has to be normal. But when we have an osteoarthritis which destroys both articular surfaces, this device is not going to help. To address that issue, the total hip replacement was introduced in early part of 1960s, by Sir John Charnley in UK. And his design is still used with some modifications today. And not only that, he also introduced two more important inventions to the arthroplasty industry. That is the plastic component of the joint. So all the metallic parts in a modern hip or knee arthroplasty moves on a plastic component. So that plastic component has to have a good quality qualities without allowing it to wear. So that polyethylene was introduced by Sir John Charnley, and then introduction of bone cement, which is used to fix the component onto bone. And talking about first total hip arthroplasty in Sri Lanka, the exact date or the year is not known, but it has been much before the total knee replacement. My teachers told me that by the time they started their orthopedic training, their teachers were doing total hip replacement and they didn't know exact date. So these are some of the pictures of initial designs of John Charnley's knee hip design. And this entire white thing is the prosthesis, which the femoral component, neck and the head is one piece of metal. And the other thing, this black line is the plastic cup, and white thing around it is the bone cement. Then that all-in-one component is not enough to solve the problem. Unlike in the knee joint, in the hip joint, we have to replace the biomechanics of the hip joint for it to function well. So each individual will have various components of the biomechanics affected, and therefore to address those things individually, we needed modularity, where we assemble the knee joint, hip joint on the table based on the patient's requirement to adjust the length, and there are various other things that technical detail I'm not going to go into. And then ideal operation theater environment for total joint replacement is that we have to have the cleanest possible operation theater and the laminar flow air circulation and surgical space suits, as you can see, to prevent anything to shed from the assistants or the surgeon onto the surgical field, and then water impermeable paper drape systems and minimum number of operating room personnel in the theater. So the maximum number of operating room personnel allowed in an arthroplasty theater is about 10. So the first total knee replacement in Sri Lanka, in a government hospital in Sri Lanka, I was in NHSL. It was called General Hospital Colombo then. I was fortunate enough to be a medical officer there. So two consultants were involved, Dr. Upali Banagala and Dr. Vasanta Perra. I have taken permission from them to say what I'm going to tell you now. And since this is a very complex operation, usually modern days, there are tech guys trained by the industry people in handling the instruments. They will assemble all the instruments for you, and then they will give it to you when the appropriate step comes. So that is currently sorted out by the tech guys. But of course, in my unit, I do it on my own. I have trained my nursing staff to do that. But in most of the other centers, there are tech guys. At that time, there were no tech guys helping the surgeon to do the first total knee replacement in Sri Lanka. So the surgeons have gone through the surgical technique monograph for nearly two weeks, trying to memorize everything. But there was a medical officer holding the surgical technique monograph describing. And whenever I was that medical officer, I was holding the book. And whenever these two surgeons had a problem during surgery, they came to me and asked me to turn the pages this way, that way, and to look for what to do next and how to assemble and all those things. And the entire operation took 7 hours, from morning till about 3 p.m. And then there was a little tea party at the end. That is how we started. But I will tell you how it is today. And thanks for these two great great pioneers in orthopedic surgery. And then my experience as a trainee, by the time I started doing my appointment in 1998, almost all our teachers were doing total joint replacement without any difficulty. And the ideal operation theater setup was not available even at NHSL. But our immediate post-op infection rates were acceptable. And I was able to do about 10 joint replacements on my own before I went for overseas training. And then after coming back from overseas training back in 2001, I was posted to General Hospital Mathura as the first orthopedic surgeon. And the situation in Mathura was nowhere near the ideal for total joint replacement. There were no dedicated orthopedic OTs. One operating room had 2 operating tables for 2 surgeons. And initially, I was doing orthopedic surgeries, including total joint replacement on one operating table, while the general surgeon was operating on the other table, which is just about 3 feet away. It may be a drainage of perianal abscess in his casualty list. So, but I did about 60 joint replacement during my 3.5 years in Mathura, and only one got badly infected. I don't know how I explain that, but that patient, of course, had a very bad infection requiring even amputation. So then I realized that not because of that infection, but I realized during that 60 knee replacements, particularly when I get a very complex reconstruction, I needed more and more learning. So to fulfill that, I started going around the world in search of knowledge and skills. These are the countries that I went to, and American Academy of Orthopedic Surgeons meetings, as Dr. Suravira mentioned, was one of the academic activity I went regularly until this pandemic started. So, and then whatever we learned, we started teaching our trainees and junior consultants. So one of the landmark teaching activity that we conducted, actually we in the sense Sri Lanka Orthopedic Association conducted were master classes. So annually we conducted them. I was one of the faculties initially, and later on I was entrusted to do the arrangement, and I was the chairman of master classes. And we always had foreign regional faculties involved in these teaching activities. And each master class is a 2 days of focused teaching and training on the target groups have been young surgeons and PG trainees. And each, apart from giving lectures and doing discussions in master classes, we felt the need of improving the hands skills of our participants. And the best way to do that are cadaver courses. And we found Thailand to be a very, very convenient place to do that. And we had many cadaver courses organized in Thailand. Thailand has several very excellent cadaver labs. And I was participating in most of these as faculty. And we always had foreign regional faculties participating. And then this is another cadaver, different cadaver lab that we conducted our cadaver courses. And then we also conducted bone bottle workshops, and it was a regular event in annual calendar of orthopedic surgeons SLOA. And then we didn't stop by training our doctors, and we thought that it is essential for us to improve on our surgical time to train our operating room personnel. This is one of the pictures of a workshop conducted for nurses in Kandy, and there were similar courses conducted by all the surgeons all over the country with the industry support. And then once we started doing total joint replacements in large numbers, we were invited to do some joint collaborative learning activities in various regional countries. This is one such event where we were invited to participate in Indonesia. You can see me observing while Dr. Umapati scrubbed to do the surgery along with the local surgeon. And then again, we were invited to participate as resource persons for various international webinars and meetings. And this is one of them where I participated as the faculty. These during the COVID period. It was a online lectures. And then I was invited also to give a lecture on Indian Orthopedic Association annual conference in 2018. And then how about arthroplasty now? All the orthopedic trainees do arthroplasty on their own as senior registrars or registrars. About average 2 to 3 arthroplasties are done in a morning list in high volume centers. Then average time for a surgery is about 1 hour. And waiting time for arthroplasty is the longest for any orthopedic operation. And more and more patients are consenting for arthroplasty at their early stage of their disease. Apart from hip and knee, currently we do total shoulder and elbow replacements. And then I was asking myself this question: how many knees have we done, or joint replacements have we done in Sri Lanka? So we don't run a national joint registry, unlike in other countries. We actually started thinking of doing it. We have developed softwares and all that, but that is not relevant to this talk. So I collected import statistics from all the suppliers of arthroplasties to Sri Lanka. So we have in total up to 2020 imported 13,905 total knee implants, and then 6,249 total hip replacements. I have broken down these total hip into total cemented and uncemented, and these addition of these two is 2,649. So then I asked the question, how common is joint replacement in Sri Lanka? I think you're also interested in where we stand in the international arena. So to do that, I compared the arthroplasty rates per 1 million population in UK and in Sri Lanka. These are the figures. And you can see the sorry state of Sri Lanka. When UK is doing 19,811 total knee replacement per 1 million population, we have been doing only 647, and 18,265 hips and 290 hips in Sri Lanka. So this is primarily because we are not getting supplies from the government, and in the private sector, it is very difficult for the patient to afford. So now, ladies and gentlemen, I move on to my statistics done in National Hospital Kandy. I have done total of 5,420 primary knees, 1,015 total hips between January 2005 to December 2021, and then revision and 48 revision hips, 62 revision knees, and then 12 primary total elbow replacements, and 18 mega prosthesis. That is a prosthesis that is used to replace an entire segment of the bone along with a joint. So that is used usually for malignancies. So now this is the analysis of total knee replacements done in Kandy by me, 5,420. This is the gender distribution. 85% were females and 15% were males. And this is how it compares with the UK. In UK, 43% have been males as opposed to 15% males in Sri Lanka. And then this is the age distribution compared with that of UK. In Sri Lanka, the peak age of knee arthroplasty is at the age of 60. 6th decade, whereas in UK, peak age is 7th decade. And after the age of 80, I have not done any knee replacements, whereas about 16% of the knee replacement recipients have been above the age of 80 in UK. And the indication profile for total knee replacement are similar in both countries, about 98% primary osteoarthritis and 1% secondary osteoarthritis and 1% rheumatoid arthritis. And surgical side, it is very strange. Right side seem to be more receiving knee arthroplasties in both countries. 54% in Sri Lanka and 53% in UK. Left side is slightly less. And then I analyzed the functional disability, severity of functional disability before and after total knee arthroplasty in 119 consecutive patients receiving total knee arthroplasty between January to June 2018. The instrument I used was an Oxford knee score. It is a score. It's an instrument to assess the functional disability, and it does not assess the severity of individual symptoms like pain, but it just assesses the functional disability only. So this is the functional severity of the 119 patients I operated on with regards to functional disability. Almost 2/3 had reported a severe disability, and whereas 4.2% reported a satisfactory function. So you might be wondering why this 4.2% came for a major procedure like total knee replacement. That must have been due to that they are convinced about the procedure, as well as they must have had severe pain. And then this is the outcome after 1 year after the replacement. Just about 83% reported as improvement to satisfactory function after the replacement, and 2.25% remained at severe disability stage. This must have been due to the inactivity of the patient before the surgery and severe muscle atrophy and in compliance with the rehabilitation protocols and so on, maybe other comorbidities. And then we were not doing a total knee replacement with ease, and we have limited resources. As mentioned before, also we didn't get enough supply of all the industry solutions with us. So doing a replacement for a very mild deformity like this, straightforward. But when the destruction is more severe, it needs more complex solutions. If you keep the tibial tray, these red lines represent the tibial tray. If you keep it perpendicular to the long axis of the tibia, there's this part of the tibial tray is uncovered. So if you leave it like that, it will definitely angulate and will be loose and in no time. So the industry solutions are, one thing is stem extension. When we put an longer stem, it will hold onto the bone and the tibial tray will not be angulated. And the other solution is the wedge. This is a metal piece that is attached to the undersurface of the tibial tray, so that will fill the gap. So we didn't have these expensive solutions in our theaters. So we get patients. So they are asking for, these are the severely disabled patients. So we had to devise something to improve their function as well. So what I did was to use a couple of screws on the medial bone defects and then fill the rest of the defect with bone cement. So this worked very well. And this particular X-ray, believe me, was taken 10 years after the original implantation. So it is still working. And this is another similar case that I did using the same technique. And we get more severe destructions like this also. So in an ideal world, we need what are called mega prosthesis to replace the entire proximal tibia for this. But I just managed to do it with a single stem extension on a primary components. So those are the sort of improvisations that we did to address. This patient has been requesting arthroplasties from several places, and then I managed to give her something what is shown here. And then the complex problems like this, where there's no internal stability, need complex solutions. This is a revision implant used on a primary purpose. And then analyzing the total hip replacement, both cemented and uncemented have been analyzed, total of 1,015. And the ratio, total knee to total hip ratio in Sri Lanka is 16 to 84, 16 total hips to 84 total knees. And whereas in UK, almost equal. So we have less knee pathologies than knee osteoarthritis and compared to the West. And then this is the gender distribution. Like for knee replacement, UK has more males undergoing knee replacement than in Sri Lanka, but it's not as bad as for the knee. And this is the age distribution of total hip replacement compared with that of UK. And this is the Sri Lankan graph. The peak age of hip arthroplasty is at the 5th decade, whereas in UK, it's at the 7th decade. So there's almost 2-decade difference in the peak age between the two countries. And beyond the age of 80, I haven't offered any total hip replacement to our patients, whereas almost 18% of the total hip replacement recipients in UK have been above the age of 80. So in UK, more elderly patients are being operated, whereas in Sri Lanka, at least in my figures, it is more younger patients. And maybe I haven't offered arthroplasty for people older than 80. And then surgical side of total hip arthroplasty, it's slight predominance on the left side, unlike in knee replacement, which was more on the right side in both countries. I couldn't get the UK figures for this. And then I did another study to see how many patients we do arthroplasty have osteoporosis, because osteoporosis, if the bone is osteoporotic, the prosthesis will get loose soon, and then we need to treat them before it gets loose. So I analyzed 500 consecutive patients who came for arthroplasty with DEXA scans. Age range was 45 to 78, and only 15 females, or 3% of females were premenopausal. And then I compared this my data with this landmark study done by Professor Sisira Siribadana and Sarath Lekambasam on community-based osteoporosis prevalence study. And these are my results. 5.6% were having normal BMD, 26.8% were osteopenic, and 67.6% were having osteoporosis. Whereas the previous study I referred to of Dr. Sisira Siribadana and Sarath Lekambasam, in the community, 61.5%, only 61.5% had osteoporosis. So therefore, patients coming with osteoarthritis has more prevalence of osteoporosis than we thought earlier. And then revision arthroplasty, I'm not going to go into details. I have done about 64 knee revisions, 48 hip revisions, and 18 tumor prosthesis implantation. And common indications for revision surgeries are aseptic loosening, where the components become just loose because of the bony structure supporting them are not supporting anymore, most likely due to the dissolution. There are various theories, but I'm not going to bore you with those things. And then septic loosening, where the joint get infected, and instability when even if the components are well fixed, if the ligament balancing is not very good, it can lead to symptoms due to instability, and periprosthetic fracture are the common indications. So this patient had a aseptic loosening of the left knee, and then I revised with the revision components. You can see how extensive these revision components are, and they are very expensive. Fortunately, I had I got about 50 revision implant sets approved from the government to Candy, and that's why I have done more revision surgeries in knee replacements. Then septic loosening. This patient's right knee was infected and it is loose. You can see sort of components are not in alignment. And then the first stage of two-stage revision was done using the spacer. This spacer, the patient can walk about and then move the knee joint, but it will kill the organisms as well as it releases antibiotics. And then the second stage of the two-stage revision was done with definitive implants. So going over to the hip revisions, and this is a septic loosening of the total hip replacement. You can see the proximal femur is destroyed, and